Good morning. I'd like to thank Rick and John for inviting me to speak today. I said I have no disclosures, but after listening to Bob and Anita, I realized that I should disclose that in the first part of my career, I was fortunate to have Mike Harrison as my mentor. In the later part of my career, Bob Bartlett, and I've watched Abe Rudolph operate on fetal lambs. And when I called him a few years ago to talk about the artificial placenta, because I had some questions about fetal physiology that I didn't understand, he thought it was pretty crazy, but Anita, he did say good luck at the end of the conversation. So here goes. So this is a Time magazine cover from 2014. I was in the airport somewhere, already doing work on the artificial placenta, and I saw this and I grabbed it, and I was so curious what Time magazine had to say about prematurity. And interestingly, they focused on a baby, as I recall, who was over 28 weeks estimated gestational age. And in fact, neonatologists should be very proud of the fact that babies born after 28 weeks, which are still premature, they actually do quite well these days. But babies born below 28 weeks still have a lot of problems, and we call them LGANs, who are less than 28 weeks. There's approximately 40,000 born a year. To give you some perspective, there's about 500,000 premature babies defined as less than 37 weeks born every year. As we all know, the mortality and morbidity is high. Among long-term survivors, the medical problems are significant, and it's a very costly problem. So I would argue that LGANs are still fetuses. They have significant organ prematurity. Their growth and development should occur in a low PO2 environment, fetal circulation and no ventilation, just like it does in the womb. And the severe complications, including lung disease, neurodevelopmental problems, NEC, etc., I would argue are largely iatrogenic in our effort to support these infants. So the solution, this is actually from the Matrix, if anyone remembers that. This looks really cool. I'm not sure we can replicate that. But in our, so let me just mention this. So this is very interesting. Dr. Bartlett gave a nice history of ECMO on the heels of the invention of the heart-lung machine. And interestingly, way back in the 1960s, with the Beatles on the cover of Life magazine, work began on the artificial placenta. So back in the day, before we had more sophisticated strategies for infants, steroids, surfactant, all types of ventilators, researchers felt like the premature infant is the ideal patient for extracorporeal support. So this work off and on has been going on for over 50 years. In our iteration of the artificial placenta, the key elements are maintaining the fetal circulation, providing the normal fetal PO2 level and the fetal environment. A critical part is no mechanical ventilation and simulated breathing with fluid-filled lungs. And I'll get to this in a minute, but our iteration involves a VV type of extracorporeal support with inflow via the umbilical vein and outflow via the jugular vein. And this is a picture of the actual circuit with jugular drainage. We have a proprietary M pump. We use a commercially available oxygenator, umbilical vein reinfusion, and the sweep glass inlet. This is a picture of the setup in our experimental lambs, and you will see an endotracheal tube in the lamb, but the lungs are fluid-filled and they're basically capped off. So I did have, early on in this work, a number of people would ask me, well, how is this really different from ECMO? So this is a table showing a few of the major differences. Obviously, with ECMO, the circulation is postnatal. We maintain fetal circulation, a low versus a high PO2. There's no ventilation. The environment is substantially different, and the anticipated duration would be long, 3 to 4 weeks. And as Dr. Bartlett pointed out, we're working on methods to avoid heparin, especially in premature infants. So this one slide is sort of 10 years of work. We began this work using a pumpless model of AV-ECLS, and you can see in the picture we cannulated the umbilical vein and umbilical artery just like nature does, but we had lots of issues with that approach. So then we went to a pump-driven AV-ECLS approach, and the major problem we had was umbilical artery spasm, and even when we bypassed the umbilical artery to the aorta of the animal, we still had issues with hypotension. So then we moved to the cannulation strategy that I mentioned, VVECLS with inflow through the umbilical vein, drainage through the jugular, and we had these animals submerged. So they were doing in an amniotic type solution, so they were doing fetal breathing movements. We had a lot of issues with infection that we couldn't solve. So we moved to our current approach, which uses an endotracheal tube and a variety of different substances. Actually, most recently, we're using perfluorodecalan in these animals, and that seems to have the best effect on lung development and avoidance of trauma. So next, I'd like to just highlight a few studies. I won't get into the weeds of them, but a few studies that may be of interest to you. So one of the studies we did in the last several years was the artificial placenta after a trial of mechanical ventilation. And the reason we did this study is we thought, okay, what is the clinical application of this technology? And what we believe is a premature infant would be born, let's say a 24-weeker, they would be intubated, resuscitated, and if we had metrics, which we're developing for failure of that therapy, then we would early on convert them to the artificial placenta, and we would see if we could go back to fetal circulation with no breathing. So in this study, this was several years ago, we used slightly more mature lambs, 130-day lambs. We used heparin for anticoagulation. We used low-pressure mechanical ventilation. We had definition of ventilatory failure, and I can tell you all of these animals, even at 130 days, they failed mechanical ventilation within 1 hour. They were already cannulated for the artificial placenta, so we then transitioned to artificial placenta support. So 6 of 7 survived at least 70 hours, and the mean duration of ventilation, as I mentioned, was about an hour. All failed due to hypercapnia, and these are the mean ABG values prior to going on the artificial placenta with very high PCO2, they're acidotic with a high lactate. So then these are the mean hemodynamic ABG values you can see on the ventilator and on the artificial placenta, and all of the parameters normalized, including the lactate. And if you notice the PO2 of 38, that is actually what we're targeting because that's the normal PO2 of the fetus. So the lessons we learned is that the artificial placenta can stabilize a moribund lamb on mechanical ventilation. It maintained and reinstituted fetal circulation. Gabe Owens was there doing the echo, so he can confirm that. Is that right? True, okay. They were hemodynamically stable, they had good gas exchange, and we also documented adequate brain perfusion. So we next wanted to, I'll show you a few more lung studies, but thus far we've had major focus on the lungs, because if the lungs don't do well, the baby dies. The next organ we were very concerned about was the brain. So we hypothesized there would be stable perfusion in this model, and we used 2 different methods. We used the transonic flow probe on the carotid artery. We used NIRS on the head. So we had 2 different methods to assess cerebral flow and perfusion. And if you look to the highlighted areas, the carotid artery flow was 23 versus 27 baseline on the placenta, and our NIRS RSO2 was good at 49%. So basically, in these animals, we also studied their brain. There was no evidence of brain bleeding, and the data suggested that brain perfusion is maintained on the artificial placenta. This is one of our favorite patients, or sheep. We called her Large Marge because she was a little bit large when she came out, and this was a number of years ago. She was also 130 days, and she was maintained on the artificial placenta only for 3 days because she was more mature. And these are some of the hemodynamic and ABG values. So after 3 days of support, she was weaned to room air. She was decannulated, recovered in the lab for a week. She was bottle fed every 1 to 4 hours. She had some physical therapy. This is Brian Gray, one of my fellows. He's a pediatric surgeon now in Indianapolis. That's actually Large Marge there, really cute. And she went to the farm and survived. And this is a picture now. It's very, you can tell how dated it is because these are my twins and they're almost 13 now. So this is a while ago. And interestingly, Large Marge had 2 sets of her own babies. So she's our favorite long-term survivor. So then an important point in our research was developing a model to simulate the lung development of a 24-week human infant. So I'm not a veterinarian, and I didn't really realize this, but in the sheep, I do know this, different organs mature at very different levels. So different stages. So believe it or not, the brain matures very early. You might not think of sheep as very smart animals, but relative to the lungs. So we wanted to find the exact gestational age in the sheep where the lungs would match in the developmental pathway a 24-week human infant in the cannulicular stage. So we looked in the literature. We also looked histologically at these animals, and we also looked at the inability to support these animals with very sophisticated ventilatory strategies. And we landed on 118 days as the equivalent of a 24-week human. So we did a study comparing the artificial placenta to mechanical ventilation controls. You can see here on the left, yes, that's an oscillator. I can't remember, Bob, but somehow we got it donated. I don't know if it went back to the NICU, but it's a true oscillator. There's no sheep saliva on it though. We actually had John Barks, the head of neonatology. He was in the lab. He was given surfactant. He was helping us with the critical care management of these infants. We wanted to give the MV control their best shot. And you can see on this slide that the artificial placenta, these animals survived on average 1 week. And the mechanical ventilation controls, again, using an oscillator, surfactant, steroids, lasted just a few hours until they had complete ventilatory failure. And this is actually our current lamb, but it's a great video that shows, oops. Go.
AP 922, MA12, it says post-op day 2.
So she's just suckling on that endotracheal tube, which is filled with perflubron. And I have other videos. They move around. We sedate them, but they move around. They're hanging out, and they basically have fluid-filled lungs. So then I want to show you just a little bit of work we've done assessing organ development. So the whole idea behind the artificial placenta would be to take a 24-week human infant who fails mechanical ventilation, transfer them to the artificial placenta, and then our goal would be to prevent any trauma to any of the major organs, but also to allow for normal development. So we want to see normal lung development during this process. We want to see normal brain development. And the idea would be to then transition to either mechanical ventilation or air breathing, and because the lungs and other organs are more mature. So we've done a lot of work on the lung. These are just a few representative H&E slides. You can see on the right the artificial placenta compared to mechanical ventilation controls. The histology looks a lot better. It's more glandular and fibrotic in the middle slide. We've worked with some lung biologists at U of M, doing a lot of staining for markers of lung development. And again, we've shown that even within 1 week time period, there's evidence of lung maturation that's equivalent to controls at that same gestational age. We then have some functional data of animals who have been on the artificial placenta for a week or 10 days, transitioned to mechanical ventilation, and then we looked at compliance, for example, and you can see that on average compliance, this, I guess, teal color is the artificial placenta, and it's equivalent to 128-day vent control. So these animals were put on the artificial placenta at 118 days, stayed on there for 10 days, and their compliance is equivalent to 128-day vent controls who were just born. Also looked at oxygenation index, and you can see that it's much lower in the artificial placenta. So this is just further functional physiologic data that these lungs, in fact, do mature and work better. Next, we looked at the brain. Again, we're very interested in injury, bleeding, and development. Turns out, because of what I mentioned before, the sheep is not the perfect model for IVH because the germinal matrix is present much earlier in gestation. However, it turns out it's an excellent model to look at white matter injury. And these are just some cool pictures. We've been collaborating with a group at WashU who does postmortem MRI, and it's a very validated tool for looking at white matter injury and other structural problems. So this is an example of cortical folding that we're looking at. And if these three brains look the same, it's because they are. The cortical folding is similar, virtually identical to controls. So this was indicating to us that this is a somewhat crude measure, but the development to some degree looks like it's continuing with the brain development. We also looked at particularly white matter injury, and we found evidence that both myelination continues with the artificial placenta, and there's no evidence of white matter injury, and we saw no evidence of hemorrhage in any of these animals. So we concluded the cortical folding continues during AP support and does not cause white matter injury. So our next step in this is to confirm some of these findings with neuropathology. So the future directions of our work is to continue evaluating organ function. We've actually done a lot of work looking at the kidney, the heart, and GI function and structure. So far, all of that looks very promising. We're going to evaluate organ structure and function now in long-term survivors. So in animals that are on the artificial placenta for 10 days, are weaned to room air, they go to the farm, and then a month later, we're going to be evaluating all those animals. We're working in our laboratory on miniaturization of the circuit and anticoagulation, as Dr. Bartlett pointed out, and preparing for a clinical trial. And it was very difficult to fit all the acknowledgments on this one slide, but I think I'd like to acknowledge and thank Dr. Bartlett, who let me work in his lab for over 12 years now, and has really provided the culture in the laboratory for this work to go forward. That's a picture above at one of our local conferences of just some of the people involved in this project. There are tons of postdoc research fellows who have done just unbelievable work. Some faculty, my partner Ron Herschel, Gabe Owens here, John Barks, Raja Rabar, pathologist, really key faculty in this project, and our many, many lab technicians and students. Dr. Bartlin's been able to amass, is it 100 a year of students, which is hard to believe. And it's actually, this work, I'll just end by saying, it's remarkable for these 1-week studies that the intensivists taking care of these animals at 2 in the morning are undergraduate students, and the animals still survive. So I think that, well, it's a testament to the students and to the technology, I think. So I'm happy to take any questions. Thank you very much for your attention.
Invite Anita back for some questions here.
To ask, so why doesn't the ductus close? Are you giving prostaglandin? Because I know you have the lower PO2, but you don't have the maternal factors that.
Yeah, that's a good question. So I think a few things. One is we give prostaglandins. We do. Yeah, so we give prostaglandins, and we maintain a low PO2 environment. And we've had some difficulties since we're using perfluorocarbon in the airway, just because we find that seems to be kind of optimal for the lung. It becomes difficult for Gabe to do the echo several days later. It stays open most of the time, but it's still a bit of a problem. It can be a little finicky. We haven't completely solved that. Do you think that's fair to say?
Yeah, I think it gets more difficult to image,
Yeah.
but for the most part, even that path on the animals that are non-survivors, we do see it's
Yeah.
still patent.
Hi. Hi, I'm Bob Shaddy from Children's Hospital Los Angeles, and I have a question for Dr. Moon-Grady. I greatly enjoyed your presentation, and congratulations on all your work in the registry. I thought I saw in one of your slides that, and I may have gone by too quickly, but a 32% incidence of fetal demise in one of the groups that did the aortic stenosis work. And my question for you is twofold with the AS issue. Is number one, how close are we, or how confident are you that the identification of the patients who are going to end up going down the single ventricle pathway is accurate and warrants potential? I don't think it's that high in most centers, obviously, but whatever fetal demise does occur, whatever the risk is there, the risk to the mother, but also to the fetus, particularly when we have not great, but a potential solution to this problem. And then when you start getting into the right side as well, even more of an issue of where does that balance occur in identifying, making sure and making confident that you have identifying the right patients, and at what point is the risk of fetal demise is too much to be able to proceed with that. So I'd like your thoughts on that.
Great, thank you for asking that. Some centers do have higher mortalities reported. Many of those were very early in their experience and had only done 3. So the overall registry fetal demise rate is closer to about 10%. So, and that's also what Boston reports in their series. Now they said that they're a little lower now, so there seems to be a learning curve. One of the things that we're planning on using the registry for, I'm very excited to have so many patients in it now, is to look at the volume outcomes relationship. And it's going to be difficult work for some of these centers to look at because, as you can imagine, we're probably going to come to the conclusion that some of them should stop. So that's dealing with the 30%. Yes, some centers probably don't have the necessary expertise and infrastructure to do this and do it well. and the diseases are so rare that we should probably regionalize where they're done. Now, should they be done at all is another question. I think that if you ask someone like Wayne Turetsky at Boston, he thinks his ability to predict HLHS is 100%. If you ask Helena Gardner, who is at UT Houston and was at the Brompton before that, she feels it's much less. And I think that in the registry there are patients who were referred for intervention but didn't have it for some reason. And so we look at those as well in these publications. And I think the answer is somewhere in between. Some patients that you think are going to have HLHS do have anatomy that gives you at least the option of a neonatal Roscono EFE resection, LV rehabilitation type of pathway without having undergone a fetal procedure. Whether or not they would have been better candidates for that had they had their aortic valve opened up and antegrade flow across it and perfusing the coronaries and better coronary perfusion during the fetal period, I don't know. I can hand wave about that. But it depends on the day of the week how I feel. Is this actually going to help them or not? I'm making it up. I think working together is the only way that we're going to be able to answer this. But people are going to continue to do it whether we work together or not. So that's the tactic I've taken.
John.
Just a brief question for Dr. Mychaliska. How did I do? Okay?
Awesome.
Not too bad. You made mention of the fact that you've avoided anticoagulation in these artificial placenta animals. How are you doing that? What's
No, I said that's the goal. So
okay.
these animals we've used heparin, but we are working other projects. Dr. Bartlett pointed out coated circuits, etc. That would be the next step, and it's an important step. I mean, it's a little bit twofold. I think the knee-jerk reaction, and a reasonable one by a neonatologist, would be if I came in with this artificial placenta to your NICU for a 24-week infant, your neonatologist would say you're not giving a 24-weeker heparin because they already have an increased risk of IVH. I think that's legitimate, but I also think there's a lot of work in the literature demonstrating that the risk of IVH in a premature infant is also increased significantly by mechanical ventilation, fluid boluses, hemodynamic instability, etc. So in this system, we avoid all of those things. So there's no positive pressure ventilation, our hemodynamics. I didn't have a chance to show you the graphs, but they're pretty stable. So probably the risk is lower, but that is still a hurdle we have to address, no question.
And one other question for your colleague, Dr. Moon. What do you think, and maybe this is way beyond, but maybe just a little speculation. Why do you think it is that we have this problem of hypoplastic left heart develop? Do we think it's primarily a valve problem, or do we think it may be something else, like something to do with the ventricle? I'd just be interested in your thoughts or speculations.
Yeah, that's really the million-dollar question, isn't it? So I've talked to Dr. Rudolph about this quite a bit because as a first-year cardiology fellow, it's all about the valve. And if you just unplug the valve, then everything's going to get better. The older I get, the less I know about fetal aortic stenosis and evolving hypoplastic left heart syndrome. I mean, let's take out the phenotype where there is no left ventricle. We're only talking about that phenotype with a small non-functional ventricle with endocardial fibroelastosis and fibroelastosis involving the mitral and aortic valves, and they're hypoplastic. I mean, it's tempting to think that this is all ischemia, but the animal models have not recapitulated this phenotype, and we don't see it on the right side. When you have pulmonary atresia, you don't see the same phenotype. So I think that it's probably something a lot more complex that has to do with the development of the heart, but also some interaction of the fetus with the placenta, and factors, epigenetic factors controlling the development of the left ventricle in most of these patients.
I mean, the other sort of tantalizing two observations are, number one, the incidence of late diastolic LV dysfunction in patients who were born with AS and who had it relieved in one way or another, surgically or by catheterization, and who now these kids are 18 or 20 years of age and have an LV EDP of 20 with no significant residual left ventricular dysfunction. And then the other interesting little observation is the incidence of pulmonary hypertension seemingly out of proportion to the left atrial pressures, in this population as well, which obviously is a particular problem for those who wind up going down a heart transplant pathway.
Yeah.
It smells to me, and I won't glorify it any better than that. There's got to be something more fundamental going on at a genetic or an extracellular matrix level, something else that is well beyond, the fact that you've got a funny-looking valve in there.
Yeah, I absolutely agree. And it does seem that the quote-unquote successes for fetal aortic valvuloplasty, they don't have hypoplastic left heart syndrome at birth. They have aortic stenosis. And one of my best patients had a postnatal aortic valvuloplasty, stopped the PGE, went home, was gaining 38 grams a day, saw him in clinic, and then died suddenly the next day at 2 months of age. So, that was an aortic stenosis type of story in the neonate. And I don't think that just ballooning open the valve is going to be the whole answer. We have to get at the root cause of why the LV myocardium is abnormal and treat that as well.
A lot of opportunities for some great research adventures for the next generation of physician scientists or the providers. I'm still the new generation. Yes. Awesome. Question over here.
Hal Walters, Children's Hospital of Michigan in Detroit, and this question's for George. I'll just avoid the last name altogether. So if you have a 120-day-old fetal lamb, that's about 80% along in their fetal development since their gestational age is about 5 months. That would correlate to about 32 weeks in a human, but I don't know that ratio really holds. How close is the histology of a...
Right, so that's a great question. So I, being a surgeon, I can make fun of myself, right? I did the same thing. I just used initially several years ago, and if you divide 24 by 40, I know.
Yeah.
We're not thinking doctors. So, and then I did the same thing for the sheep. It turned out to be a 90-day lamb, which was actually very difficult to work with. Yeah. We did keep them alive for a few days. They were like, the tissue was like, really difficult to work with. But turns out when we actually looked at the histology, the 118 day is equivalent to a 24-weeker.
Great. Thank you.
I'd like to ask Marcus Hall from Davos. I'd like to ask Dr. Emma a question. The histology slides were really fascinating to me because in a different life 20, 30 years ago, I was looking at rat lungs and lung injury. So I think you've got a spectacular improvement in the lung histology, which seems to be the big problem with the neonates. Do you think that that's mainly because of your placental circulation or because of the fact you're perfusing them with a fluid rather than mechanical ventilation?
I think it's almost certainly because they're not being ventilated. So we have a number of different experiments, and those were just a few slides, but a couple interesting things I can tell you is that in the animals that we went straight from the womb to the artificial placenta, basically we did an exit procedure in the sheep where they received no mechanical ventilation. A week later, those lungs look pristine because, and this is quite clear in the literature. Even a very short period of mechanical ventilation, an hour on a premature lung, it causes problems. So we saw that. The other interesting observation is that we have some animals where we instilled fluid of different types, and on some of them that we capped them off, it's essentially equivalent to tracheal occlusion. So what we saw in a week is that that actually stimulated lung development. So it was a little bit further along in the developmental pathway. And then lastly, of the different fluids we've used, like the actual amniotic fluid from the mom, versus perflubron or perfluorodecaline that we're using, that seems to be most protective to the lung. So there's less evidence of injury. But I think it's all or largely due to the absence of mechanical ventilation.
A question from Bob.
George, has anyone tried to corroborate this experiment?
Right. So it's interesting. So now there, you may have heard the group at CHOP has also developed an artificial placenta, and they've published their work recently, and they've corroborated our findings. And in fact, their work is impressive for the fact that they have shown survival and growth of animals for 1 month, which I think is great, and they have some great data supporting that. Their model is different than our model in that it does use the umbilical vessels. They have found a way to prevent umbilical vein and artery spasm, but in my mind, it's not clinically relevant because these patients, human patients, would have to get an exit procedure during a precipitous premature delivery, and once there's any spasm of those vessels, their whole machine goes down. But in the animals, they've done some great work, I think.
Sue?
I'm Sue. I'm from the University of Michigan, and I have a question for Dr. B. So one of the interesting things about innovation and research to me is that it can have spillover to other areas. And Dr. B, I'm wondering if you could talk a bit about the nitric oxide generator that you're working with in the lab and the future implications it could have an effect on in the ICU care environment, OR, cath lab, and transport for patients.
I think that was a question for you, Bob.
So you asked about a nitric oxide generator. Oh, thank you. Yeah, and I must say this is, from my point of view, really exciting stuff, especially for this audience, because you use a lot of nitric oxide. And in certain situations, particularly neonates with pulmonary hypertension, it's magical. There's nothing like it. But it costs a whole lot of money to do it. And it's the concept was developed and marketed by a single company, Icaria, so they could charge whatever they want, and they charge a whole lot of money. It used to cost $12,000 just to open the tank. I don't know what it is now. So that company was acquired by Mallinckrodt. They charge even more. So that's a factor. So imagine if every cardiopulmonary bypass case you're going to put nitric oxide in. Are you getting thousands of dollars per case? So because of that, we've got working on other approach to nitric oxide. I say we means Mark Meyerhoff, who is a brilliant chemist. He used to be chairman of the chemistry department. He and I have been working on using nitric oxide to prevent platelets from sticking to surfaces. The quick summary is he's developed a way to put a reagent in a little cup and put electric current in it, and out of it comes pure nitric oxide in unlimited quantities for pennies. So sooner or later, maybe we'll convince the university to help us develop this, and if you want to buy into that company, let me know.
Great.
Thank you, Dr. B.